The three components of adequate blood circulation are hardest pump, circulating blood, and vascular tone. The common pathway in all types of shock is decreased perfusion of body tissues. So remember that. Shock pertains to a decrease in perfusion of body tissues. When tissues are not perfused, cellular metabolism is impaired. For example, there's impaired use of oxygen as well as impaired use of glucose. Shock is classified as cardiogenic, caused by pump failure, or as hypovolemic, caused by insufficient intravascular volume, or as distributive or vascular shock, caused by alterations in blood vessel smooth muscle tone. Distributive shock includes three types of shock that share the same basic circulatory pattern. With neurogenic, you have overstimulation of the parasympathetic system and understimulation of the sympathetics. Anaphylactic shock, which is caused by hypersensitivity, and septic, which is caused by infection. An additional type of shock is called traumatic shock, and it combines hypovolemic and septic shocks. Cardiogenic shock. Cardiogenic shock occurs when the heart is unable to pump adequate blood to tissues and organs. It's a medical emergency because it's often fatal. 50 to 80% of patients who develop cardiogenic shock die. Their deaths can be prevented by early revascularization, in other words, giving them fibrinogen agents to break up the clots in their coronary arteries, and performing percutaneous interventions such as balloon angioplasty to open the coronary blood vessels during an acute MI. Also, cardiosupportive drug regimens are given and fluid regimens to maintain adequate blood pressure, and mechanical assistive devices such as intra-aortic balloon pumps to support cardiac output temporarily until the person improves or transplantation is possible, for example, and a pacemaker is put in. The decreased contractility that leads to cardiogenic shock can occur due to ischemia, which occurs with an acute MI, or with impaired diastolic filling, which occurs with bradyarrhythmias, heart block, and tachyarrhythmias, such as AFib, A-flutter, and VFib. Also, it can occur with obstruction, which occurs with cardiac tamponade and valvular diseases, such as mitral stenosis. With cardiac tamponade, it can occur due to an acute MI, placement of a central line. What happens is that you have blood or fluid that collects in the pericardium, the sac surrounding the heart, and that prevents the heart ventricles from expanding fully. The excess pressure from the fluid prevents the heart from functioning normally, and as a result, the body does not receive enough blood. The most common cause of cardiogenic shock is an MI. Most patients who die from cardiogenic shock have extensive damage to the contracting muscle of the left ventricle because of a recent infarct or a combination of recent and old infarctions. But regardless of the cause, there's failure to eject blood from the heart, there's hypotension, and an inadequate cardiac output. Please refer to the appendix section of the main PowerPoint for a deeper discussion on dysrhythmias. And for a deeper discussion on cardiac tamponade. So in looking at the pathoschematic for cardiogenic shock, as a review, you have a person who's had an MI, so you have necrosis and thus decreased contractility, which decreases cardiac output. Hence, you're going to have a neurohormonal compensatory mechanism stimulated. In other words, the stress response will be set off, which means you have activation of the sympathetic nervous system, and therefore there's a release of catecholamines that will cause vasoconstriction and the heart rate to increase. With vasoconstriction, that's going to in turn increase the systemic vascular resistance, the SVR. That increases afterload. What also happens is that you're going to activate the renin-angiotensin-aldosterone system. Remember, if you have decreased cardiac output, then there's less blood and thus less oxygen going to the kidneys. With decreased renal perfusion, you activate the renin-angiotensin-aldosterone system. You do that because you want to try to increase blood volume. There's also a release of ADH, anti-diuretic hormone. You don't want to diurese. So ADH is released from the pituitary gland. That causes the body to hold on to water, which increases blood volume. Specifically, it's the kidneys that holds on to the water. With an increase in blood volume plus afterload, you succeed in normalizing blood pressure, but at the cost of increasing myocardial demand for oxygen and nutrients. That further strains the already failing heart. So you have pump failure plus increased afterload, which in turn increases preload. With increased preload, you have an increase in stroke volume until a point of overstretching the heart. Because the heart rate is failing, however, the stroke volume actually will decrease, and that causes a decreased cardiac output, leading to a decrease in blood pressure, because the heart can no longer pump an adequate volume of blood with sufficient force, and tissues will not be adequately perfused, and that impairs oxygen use and it impairs glucose use. So thus you have impaired cellular metabolism. In the patient with the infarct in the left ventricle, you have left pump failure, and thus you have a decreased left ventricle contraction, also known as systolic dysfunction, which decreases cardiac output. That in turn increases pulmonary capillary static pressure, causes pulmonary edema, and leads to the clinical presentation of patient being dyspneic, having crackles and wheezes. With right-sided pump failure, you'll see peripheral edema. Hypovolemic shock. Hypovolemic shock is caused by a large amount of volume loss. Loss can be via an external loss or third spacing. With external loss of whole blood, for example with hemorrhaging, whether traumatic or GI related, such as an ulcer or varices or an obstetric postpartum hemorrhage, pretty drastic, and death rates from traumatic hemorrhagic shock ranges from 10 to 31%. Treatment involves prompt control of hemorrhage and fluid replacement. External losses of plasma, which can happen when one suffers a severe burn, can lead to hypovolemic shock. Also, external losses of extracellular fluid, which can happen in the case of severe dehydration. Severe dehydration can occur with diaphoresis, loss of GI fluids with vomiting and diarrhea. Then there's third spacing that can lead to hypovolemic shock, and this occurs due to the result of fluid shifting from the vascular to the extravascular space. And that occurs with internal hemorrhaging due to a rupture of, say, a major vessel aneurysm and small bowel obstruction. Hypovolemic shock can develop as a result of the shift of fluid into the bowel lumen. And other causes of hypovolemic shock are DI, diabetes insipidus, diabetes mellitus, and diuresis. For a discussion on how placental abruption is related to hypovolemic shock, please see the appendix in the main PowerPoint. Hemorrhage may be classified by symptoms and signs that generally are associated with corresponding degrees of blood loss. For class 1, that represents a normal, healthy state. And this is the initial stage of blood loss, whereby if it's less than 15%, you'll have relatively normal values in terms of blood pressure, the person's respiratory rate, their pulse, and their urinary output. The mental status as well, you'd expect that to be normal. Once the person loses 15 to 30% of their blood volume, they're in class 2, And at that point will be an inadequate filling of the vascular compartment, and that's where hypovolemic shock begins. In other words, the person will begin to compensate. So if you think about the fact that the person is losing their blood volume, they're going to have a decrease in blood pressure. If the blood pressure is decreasing, the heart is going to compensate by increasing its rate. So you have tachycardia occurring. The pulse will be anywhere from 100 to 120 beats per minute. The respiratory rate will increase as well, so there's tachypnea, and you can expect a range from 20 to 30. The urinary output, however, is going to decrease. So it's not going to be above 30 cc's per hour. It's going to be between 20 and 30. And the reason being that you're going to have a decrease in output, that yes, you have less volume on board, but at that point the body is compensating by holding on to the fluid that is already there, the fluid that's remaining. The person is going to be anxious. You can imagine they're going to be stressed, so the stress response will be triggered. Once the person loses another 10 more percent, so anywhere from 30 to 40% of the blood volume, they're now in a progressive stage of hypovolemic shock. And those same indicators or symptoms of going into the shock are going to be there, but more pronounced. So the pulse rate will be even higher, anywhere from 121 to 140. The blood pressure is going to decrease more, okay, particularly the systolic blood pressure. Now, in terms of the respiratory rate, that's even higher. That's at 30 to 40. The urinary output, you can imagine, is going to be even less, 5 to 15. You have oliguria, and the person's confused. Just to backtrack about the blood pressure in terms of class 2, it's the diastolic pressure that goes up. The systolic begins to drop, but the diastolic increases. So when you see the class 2 and the blood pressure being above 100, we're talking about the diastolic there. Okay, going back to where we were and moving on to class 4, the person's beginning to get confused, and at that point they're in a refractory stage. The tachycardia is marked. You are above 140 beats per minute, so you can imagine that the heart rate is not going to be effective. The heart is not going to pump effectively to really have a good cardiac output. So the blood pressure, you're going to have both a decrease in systolic as well as diastolic blood pressures. The respiratory rate is well above 35, and the urinary output is markedly reduced in that it's negligible. And this person, at this point, will be extremely lethargic and even lose consciousness. The skin will be cold and pale. To take a look at a pathoschematic for hypovolemic shock, hypovolemia, again, is initially offset by compensatory mechanisms. So this is what you're seeing here in the initial phases. So in other words, the stress response occurs. That means that the sympathetic nervous system is activated. Catecholamines are released from the adrenals. So there's vasoconstriction, and there's an increase in the person's heart rate. Vasoconstriction causes resistance. Okay, so there's an increase in systemic vascular resistance, SVR. That increases afterload. Anytime you have constriction, you're going to have an increase in afterload. When you increase afterload, okay, then you will increase cardiac output. So remember, we're trying to get more blood to the tissues to perfuse them. Now, because there is a decrease in blood volume and a decrease in blood pressure, the kidneys pick up on that, and hence turn on the renin-angiotensin-aldosterone system. So whenever the kidneys are hypoperfused, either from a low blood pressure and or a hypovolemic state, the kidney sense that and says, hey, we need to get our blood volume up. We need to increase the pressure. So what happens is that renin is released from the kidneys, the juxtaglomerular cells. Once renin is released, it tells angiotensinogen in the blood to convert to angiotensin 1. After angiotensin 1 is made, the blood circulates, gets to the lungs, meets up with ACE, angiotensin converting enzyme, gets turned into angiotensin 2. Now that we have angiotensin 2, that causes vasoconstriction, and it also causes aldosterone to be released from the adrenal cortex. Now that aldosterone is released, think sodium. Okay? Aldosterone causes the kidney to hold on to sodium. Wherever sodium goes, water follows. So now that water moves into the bloodstream, okay, from the tubules into the bloodstream, we increased our blood volume. Now we have an increase in cardiac output. So both with the sympathetics causing vasoconstriction as well as the holding on of sodium and water, we are now going to get an increase in our blood volume and increase our cardiac output. Once we've increased our cardiac output, things are relatively normal. But with more volume loss, this compensatory mechanism is not going to help the person, and the cardiac output will then decrease. Okay? And then once the cardiac output decreases, then this causes a decrease in tissue perfusion. For a review, just to back up a little bit about the decrease in cardiac output and with more volume loss or a decrease in intravascular volume, the reason that there's a decrease in cardiac output is that when you have less blood on board, you have a decrease in venous return, and that leads to a decrease in ventricular filling or a decreased preload. And so whenever you have a decreased preload, you're going to have a decreased stroke volume. And with that decreased stroke volume, that causes the decreased cardiac output, which then leads to a hypotensive state or a decrease in arterial blood pressure. And that's how you get the decrease in tissue perfusion and then impaired cellular metabolism. So clinically, for hypovolemic shock, you will see in high SVR, systemic vascular resistance, but poor skin turgor, triggering thirst, having an oliguric stage, and having low systemic and pulmonary preloads and rapid heart rates. Neurogenic shock. In terms of the patho for neurogenic shock, let's just talk about the factors that stimulate parasympathetic activity or interrupt sympathetic activity of vascular smooth muscle. And those would be injury to the brain or spinal cord, or anesthetic agents, or severe emotional stress or pain. These things lead to vasodilation for an extended period. So in other words, blood volume doesn't change, but the amount of space containing the blood has increased. Therefore, this leads to a decrease in SVR, a decrease in systemic vascular resistance. And as a result, the pressure in the vessel becomes inadequate, and that causes the decrease in cardiac output, which results in decreased tissue perfusion, which then leads to impaired cellular metabolism. Okay, and the reason the metabolism of cells is impaired is that it's not getting the nutrients that it's to work properly. A classic symptom seen with neurogenic shock is bradycardia. Anaphylactic shock. With anaphylactic shock, you have an allergen and then a hypersensitivity reaction to occur. In other words, an immune and inflammatory response to an allergen occurs. An allergen is an antigen to which a person is hypersensitive. For example, shellfish, penicillin, pollen, animal sera, or insect venom. And that causes a vascular effect due to extensive immune and inflammatory responses. So we talked about this with the inflammation PowerPoint. When you start the inflammatory process, you have a release of chemical mediators, for example, histamine, that causes peripheral vasodilation. So with vasodilation, you have more blood that comes to the area. And because you now have more blood in the vessel, once this increased blood volume, this hyperemia, okay, occurs, and you get to the capillary area, which are these thin-walled vessels, they don't have muscle, they can't stand high pressures, okay? You're going to have fluid that then seeps into the tissues. And I'll recall that histamine pulls the junctions apart of the endothelial layer, the endothelial cells in the blood vessel. So you're going to have fluid leaking from there. Proteins leak too. So now, again, you've got this peripheral pooling and tissue edema because you had this proteinaceous fluid that's leaked out. So you have exudate, the proteinaceous fluid, and you have transudate, the fluid that just seeped out from the high pressures. So now after that occurs, okay, with histamine being released, how it acts on extravascular smooth muscle, and it causes constriction, okay? So particularly of the airway walls, like the larynx and the bronchioles. And the GI tract has constriction, again, so that's smooth muscle, that's extravascular smooth muscle. Okay, we're talking about smooth muscle outside of or other than the blood vessel. And that leads to respiratory difficulty as well as GI cramping. With the peripheral vasodilation and increased vascular permeability, you are going to have hypovolemia. So this is not the same kind of hypovolemic state where you actually have blood that's leaving the body, okay, such as someone that's having an external wrench. This is a case where the leakage of fluid is going into tissue. And so it sort of mimics loss of blood outside the body, but it's not quite the same, okay, or it is not the same. You're still going to get the decrease in cardiac output, however, because you do have less volume within the vessel, and so that leads to decreased tissue perfusion and impaired cellular metabolism. Septic shock. Septic shock is the end result of progressive worsening due to bacteremia. The syndrome begins with inflammation, sepsis follows, then severe sepsis follows, and then septic shock occurs. And septic shock is the 11th most common cause of death in the U.S. 28 to 60% of persons die from it. It can be caused by a gram-negative or a gram-positive bacteria or fungi. And what happens is that you have bacteria that enter the blood either directly from infection, or you have this issue occurring or entering the blood. The bacteria releases endotoxins directly into the bloodstream. Either way, the inflammatory process gets triggered and you have chemical mediators released. Again, so histamine, complement, kinins, All those cause vasodilation and increased vascular permeability. Leakage of fluid out of the vascular compartment into the interstitial compartment, leading to edema and relative hypovolemia, just in that anaphylactic stage, the relative hypovolemia. That leads to a decrease in cardiac output and hypotension and high blood pressure. This situation with inflammation, you have macrophages that are involved. And recall that macrophages secrete necrosis factor. Tumor necrosis factor activates the coagulation cascade. So we increase clotting throughout the microvasculature. So that's just bad because you've got ischemia and tissue damage all over. So you can expect to have end organ failure. So like liver, kidneys, this is going to like shut down. When you're affecting the kidneys that way, you're going to have acute renal failure. There's issues going on with the spleen and the lungs, and this leads to acute respiratory distress. So with the kidneys, specifically, if you have decrease in oxygenation, you stimulate the inflammatory response, and then you know that part of the inflammatory response involves repair. Well, then if you start repairing and start covering up this hole, if you think of a strainer in terms of the kidneys, you start covering those holes with fibrous tissue, then there's a problem with getting rid of the amount of toxins and fluid that you need. So on the one hand, when you have initial inflammation, you let go of protein and things that you don't want to let go from the kidney. And on the other hand, when you hit the healing phase of it, you hold on to stuff you're supposed to get rid of, like urea. So BUN goes up. Again, we're talking acute renal failure. Eventually, the increased clots begin to clotting factors and platelets. So just think, you've got all this blood that's pooling and you're trying to clot to stop it. You use up the clotting factors, and so then what happens if you use up clotting factors? You can't clot. So then you have this paradox where you have more bleeding out. So you have DIC, disseminated intravascular coagulation. It's a serious complication of septic shock where you have this bleeding and clotting kind of thing and going back and forth. So signs and symptoms of this would be blood oozing around an IV insertion site. Previously stable incision sites may begin to bleed. You may see blood in the person's urine, so hematuria. When they cough up blood, hemoptysis, and they may have spontaneous intracranial hemorrhages. Okay. With ARDS occurring, that's activated by the macrophages secreting tumor necrosis factor as well, fibrin clots, ischemia, and that also activates neutrophils because macrophages cause neutrophils to be recruited. The neutrophils release this destructive proteolytic enzyme, oxygen-free radicals, and inflammatory mediators. And what happens is lungs become leaky, and you have this protein-rich exudate that gets into the interstitial spaces and the alveoli, and that results in pulmonary edema. It interferes with gas exchange. Now, because inflammation in this area damages type 2 pneumocytes, you have a decrease in surfactant production. So you need surfactant to keep your alveoli nice and inflated. So without that surfactant, then the alveoli collapse and there's an increased effort to breathe. So that occurs due to pulmonary edema and the alveoli collapsing, so atelectasis. And with, I told you about the acute renal failure, so I don't need to go back over that in terms of decreasing GFR, glomerular filtration rate. So when organ dysfunction develops in two or more systems, it's called MODS, M-O-D-S, multiple organ dysfunction syndrome. So you have an overactive and destructive immune mechanism, ongoing inflammation leading to tissue destruction and dysfunction. With septic shock, you have different phases. You have a warm shock, phase. That's the first phase, and you have cold shock. With the warm shock phase, the person is that's characterized by a high cardiac output and low peripheral vascular resistance. So there's vasodilation from the effects of those chemical mediators that we talked about, and that dramatically decreases the total PVR, peripheral vascular resistance. So it also makes capillaries more permeable, causing leakage and fluid to shift into the tissues and physiologic third spaces. Two other factors contribute to vascular fluid loss, and that's fever. That's caused by the endogenous pyrogen released by your leukocytes attacking the gram-negative bacteria and the patient's high respiratory rate. With the cold shock, or the late stage, most patients will remain warm for about 6 to 72 hours before they enter cold shock. Cold shock is also known as low output or high resistance shock. It's late phase, irreversible, and it's indistinguishable from terminal hypovolemic shock. To compensate for the patient's profoundly diminished plasma volume, you have that stress response that's being turned on to try to increase the cardiac output and myocardial contractility, but those effects won't be strong enough to keep the blood pressure up. So eventually, tissue perfusion becomes inadequate, resulting in a loss of cellular energy and increased lactic acid production. Two ominous signs of cold shock are subnormal temperatures and a low white blood cell count with many immature cells. You can imagine you're trying to fight the infection, but recall that neutrophils, they die after one little round of phagocytosis, so you try to compensate, produce more white blood cells, particularly neutrophils, and they're babies because they don't have time to mature to keep up with this infection they're trying to fight off. They get moved from the bone marrow into the bloodstream, and they're just ineffective because they're not grown up. Now, when you think of your cardiac output decreasing, let's just talk about the cold shock a little bit more. The catecholamines cause selective vasoconstriction, for example, in the renal circulation, with the increased coagulation in the microcirculations. That leads to ischemia. And that ischemia turns on or causes MDF, myocardial depressant factor, to be released from pancreatic cells. And that, too, contributes to a decrease in cardiac output. So if you have a patient in septic shock, you can expect that person's therapy to be geared towards three goals. You want to find and eradicate the cause of the gram-negative infection. You want to support the cardiovascular system, and you want to prevent and or treat complications. So let's review compensatory and then decompensatory phases of shock. So stage one, during the initial stage of shock, cells begin to change due to decreased perfusion. So there's less oxygen to cells, and that brings on anaerobic metabolism. As a result, metabolic acidosis or lactic acid production occurs. With stage two, during the compensatory stage of shock, the body tries to reverse the results of the initial stage. With cardiogenic shock, we have pump failure that causes decreased cardiac output, triggering the stress response to try to compensate. With hypovolemic shock, we have a decrease in intravascular volume that leads to decreased cardiac output that stimulates the stress response to try to compensate. With septic shock, we have bacteria leading to an inflammatory response causing chemical mediators to be released, vasodilation, then increased vascular permeability, leading to leakage of fluid out of the vascular compartment into the interstitial compartment, leading to edema and relative hypovolemia, which leads to a decrease in cardiac output and hypotension, there triggering the stress response to compensate. Okay, so with any of these situations, we are going to trigger the sympathetic nervous system to release catecholamines. That increases peripheral vascular resistance due to the stimulation of alpha receptors on arterioles and most parts of the systemics. Venous return to heart occurs due to stimulation of alpha receptors on veins. With beta 1, we're going to have an increase in heart rate and contractility. With beta 2, we're going to have vasodilation to select areas like your brain, your skeletal muscle bed, and relaxation of bronchioles. Okay, moving to the kidney. Renin is released, and ultimately we're going to get angiotensin II, which causes vasoconstriction, and we're going to have testosterone being released because of that. So now we're going to hold on to sodium and hold on to water subsequently. With our decrease in intravascular volume, we have decrease in capillary hydrostatic pressures, which causes interstitial fluid to move into the vascular compartment. And, excuse me, it's the decrease in intravascular volume, decrease in capillary hydrostatic pressure, yes, will cause an interstitial fluid to move into the vascular compartment. So that increases heart rate and vasoconstriction, and that occurs in most kinds of shock. So now we have an increase in blood volume, which will increase cardiac output. So other compensatory mechanisms, we have lactic acid being used as fuel. So it's used as a fuel source, but only for a limited time. And the person also hyperventilates to blow off excess carbon dioxide. So the buildup of acid, remember, due to impaired cell metabolism is occurring. And you're trying to get more oxygen to flow through the system. The decompensatory or progressive stage of shock, stage 3, the initial cause doesn't get corrected and damages become more severe and can be irreversible. So cellular function continues to deteriorate. In other words, anaerobic metabolism leads to increased metabolic acidosis. And compensatory mechanisms can no longer maintain the balance required to protect the person's organs. So you have a maldistribution of blood flow caused by generalized vasodilation, selective vasoconstriction, and increased vascular permeability. The organs most affected or most severely affected by decreased blood flow are the lungs and the kidneys. Okay, because you have this selective vasoconstriction occurring. So recall decreased blood volume, hypotension, of renin, increased Ang2, arterial vasoconstriction. Microvascular permeability leads to interstitial edema, leads to impaired tissue perfusion. Blood is shunted past selected regional capillary beds. With the ischemia that's occurring, you have a release of MDF, myocardial depressant factor, so you depress the heart rate. Therefore, that contributes to the fall in cardiac output and causes worsening tissue perfusion. Okay, so the refractory or late phase, there's profound vasodilation unresponsive to catecholamines. That usually occurs. So the vascular bed widens, the blood pools, there's an increase in vascular permeability, which leads to an increase in viscosity because the fluid part of the blood is seeped out. So now you have this hemoconcentration in the blood vessel. So that makes things sluggish and harder to move along. And blood flow slows, so you have prolonged ischemia due to this decrease in flow, and that causes tissue hypoxia. So there's less oxygen to tissues. That causes anaerobic metabolism because you don't have oxygen there, and that leads to metabolic acidosis. So following, you have tachycardia, tachypnea, and altered mental status. In other words, this is following stage 3. And the person enters stage 4, whereby the lungs begin to fail. So recall that in all types of shock, the lungs are a common target of immune-mediated damage. You have ARDS, acute respiratory distress syndrome occurring, and that will impair gas exchange. That leads to respiratory acidosis. The metabolic acidosis that's going on concurrently leads to organ failure and death. Please take a look at this slide. You can compare it with the slide that we talked about in terms of the signs and symptoms that you see with the person going through the hypovolemic shock, in terms of what's seen when the person's compensating, the tachycardia, the diastolic blood pressure increasing, the respiratory rate increasing, and the urinary output decreasing, person being anxious. Skin may be kind of cool and clammy, and we go to stage 3 of the progressive stage. Now the pulse is even higher. You begin to see a decrease in systolic blood pressure with the increase, in blood loss or increase in symptoms. The respiratory rate goes even higher, and the urinary output gets even lower. And at this point, the person's confused. And then class 4, the preterminal or refractory stage, pulse above 140, marked tachycardia, decrease in both blood pressure, systolic and diastolic. Respiratory rate really high, and urinary output negligible. Persons lose consciousness. This is a review slide of key symptoms I want you to hone in on. In terms of neurogenic shock, bradycardia is a classic symptom. Classic symptom for anaphylactic shock is wheezing. Okay, and then when you talk about the septic shocks, early stage, the skin is warm and is flushed, and as shock progresses, the skin becomes cool and clammy. As a review of the systemic effects of shock, the clinical manifestations of failure of individual organs in MODS, multiple organ dysfunction, are caused by inflammatory mediator damage and tissue hypoxia. And causes include sepsis, but can be due to severe trauma and circulatory shock. Primary MODS occurs due to initial insult, for example, trauma. The generalized hypoperfusion in primary generally cannot be detected clinically. With secondary MODS, you usually develop symptoms days to weeks after your primary insult, and sepsis and septic shock are the most common causes of secondary MODS. So for the first 24 hours after insult, you will have a low-grade fever, tachycardia, tachypnea, dyspnea, altered mental status, and general hyperdynamic and hypermetabolic states. 24 to 72 hours after, the lungs begin to fail and ARDS may occur. So with ARDS, you have tachypnea, pulmonary edema with crackles, diminished breath sounds, and use of accessory muscles and hypoxemia. You hit day 7 through day 10, you have hypermetabolic and hyperdynamic states. And the bacteremia with enteric organisms are common, so signs of liver failure develop, as well as intestinal and renal failure. Days 14 to 21, renal failure and liver failure are quite severe, and you have hematologic symptoms and heart failure and death. So with liver failure, the symptoms will be jaundice, abdominal distension, muscle wasting, and having a difficulty detoxifying, uh, medications, hormones, vitamins, with renal failure, signs and symptoms are oliguria and even anuria. So no urinary output. It's so negligible. It's just like you just say none. And hematologic wise, you have DIC, disseminated intravascular coagulation. In terms of symptoms of heart failure, initial symptoms: tachycardia, a bounding pulse, increased cardiac output, a fall in SVR, hypotension, warm skin, and dysrhythmias. Late symptoms of heart failure: profound hypotension and dysrhythmias. CNS-wise, ischemia and inflammation are responsible for changes such as agitation and a decreased LOC. When ischemia is severe, the person will have seizures and can even go into a coma. This concludes the discussion on shock. Should you have any questions, please contact me at halef@hawaii.edu.